Thanks for joining us. And where are you from and why do you do what you do?
Basically, originally, I am from Kerala and also settled as a psychiatric social work faculty at NIMHANS. So my basic background is I'm a postgraduate in social work and continued my MPhil and PhD at NIMHANS. And then I became the consultant at NIMHANS. The current position is last 10 years I'm working as a faculty here at NIMHANS, and the current position is additional professor in psychiatric social work. And I also am a consultant in advanced psychiatry as part of the clinical team.
Even with more awareness in recent years, so a lot of people say that most Indians who have like depression or serious mental conditions, they still don't have access to treatment. So in your view, what are the real barriers for accessing care today in India?
Yeah. So you have a global statistics, say maybe from US, you can see 1 in 5 have mental health issues in lifetime.
Hmm.
NIMHANS National Mental Health Survey 2016 report, you will see 1 in 7 have mental health problems. And we have statistics of the same survey, 13.7% have common mental health problems sometimes in their lifetime. So that is the basic statistics. Same time, we also have data saying that 80% of the people, either common mental health problems or severe mental health problems, they're not taking treatment. Some of them, they don't take from the treatment from professional, trained clinicians. They take from some faith healers, sometimes from semi-qualified professionals. So they may sometimes take only psychotherapy where they are supposed to take medication as part of their recovery. Or sometimes they take medication, they won't take psychotherapy. So both ways we can see. People are, some cases we are supposed to take both
Mhm.
medication and psychotherapy. And
If
sometimes
po-
people,
Yeah.
yeah, yeah, sometimes, first line of treatment will be therapy, but they will take medication first. So these kind of things we are seeing in our, because we know about mental illness, but even today we are not very clear whom to approach, where to approach, and what kind of treatment is required for the different types of mental illness. A major barrier is different types of mental illness and treatment for different types of mental illness. It is not very clear in our society even till today. So that is the reason we'll go and approach a psychotherapist for our severe mental illness, and they will miss your treatment. And you'll go and approach a psychiatrist for a kind of adjustmental issues. That person will be missing his your problem, because there is there's a proper clarity about where to treat or from whom to take treatment. That clarity is still lacking. And many places they do individual practice. Psychiatrists will be practicing individually. Psychologists will be doing individual practice, and then they won't be doing complementary roles in their care. Ultimately, global gold standard is a multidisciplinary team is supposed to address any person's mental issue. In India, it is not happening.
Is cost the biggest barrier? Because even if you want to go for therapy today, they might charge you like minimum 1,500 rupees to 3,000 rupees. So do you think that is also a barrier these days?
You are right, absolutely right. For district mental health program, also I am covering here. We have started a national mental health program and district mental health program to reduce the cost of mental health care. Fortunately, this national mental health program could develop many centers of excellence, but we couldn't develop enough professionals who are ready to work at grassroots level or a small towns. So this is a major failure in the national mental health program. Same district mental health program, we have created multidisciplinary team, but many places these posts are vacant, like qualified psychologists, qualified psychiatric social worker, or sometimes psychiatrists will be there, may not be full time, no, they will not be able to deliver services. So we can see this kind of system related issues. Second issue is the cost. You are right. When service is less, cost will increase. Demand and supply economics, health economics matters here. Very less number of trained professionals, and they are skewed to urban area, urban based clinic. naturally they will select cases who can afford therapy. So
Mm-hmm.
there is a divide in the affordability. Less number sufficient therapists and less excellent centers, and this treatment definitely will be costly. Your information maybe 1,500 to 3,000. My information is here 2,000 to 5,000 is the therapy cost.
Yeah.
And the psychiatric consultation also ranges from 1,000 to 3,000. It may be 10 to 15 minutes service of normal consultation. It is scary.
Yeah.
You need care, but you don't have enough people. Or there are people, but which we cannot afford.
Yeah.
But we have planned for covering these services under insurance schemes. This health insurance should cover the service of both psychiatric consultation and psychotherapy. But it's not happening fully. That is also a challenge in this area.
There are like lot of new apps and more number of therapists compared to earlier, right? But still, why are people not getting better according to you?
You see, these chat based or chat boards or digital things are helpful us to identify we have some problem. That level, it has grown up. But in therapy, a major element is therapeutic alliance or an empathy. Corporate's mission is expressing empathy. I'm skeptical about that.
Mm.
For example, you can have watch Instagram, Facebook, hours together. But how much empathy you experience through that digital communication?
Yeah.
Yeah, you get information, but you don't feel that your feeling is understood by the mission. There comes the again. We should not be very pessimistic about technology. We need to improve our chatbots and the digital therapy for early identification, screening, then tuning it for self help kind of guides.
Yeah.
We know that heart attack and all self help doesn't work, right?
Mm.
Somebody gets heart attack or stroke. Will self help work?
No.
No. You need immediate medical care.
Yeah.
Self care is also equally same,
Mm.
like stroke or heart care, no cardiac care. It requires medical care.
Yeah.
The self care to an extent it will go.
Yeah. Absolutely.
And we lose many people in suicide because they depend more on self care than on medical care. So this transition, public health understanding, no campaign is very essential.
Okay.
Somebody gets chest pain, you can drink the ginger tea or all those things for handling, thinking it is a gastritis.
Yeah.
Sometimes it will cost your life.
Yeah.
Suffer a lot, right? No?
But there's a lot of talk about like people saying AI will replace therapists and
In 100 years, I can tell you the next 100 years, AI is not going to replace any medical care.
Mhm.
Because it is that complex and it requires that kind of multidisciplinarity.
Okay.
So AI is not going to replace mental health care at all. I'm speaking because I'm sitting in an institute, premier institute that represents the interest of 140 crores population.
Yeah.
And we are informed for last 100 years. I can tell confidently next 100 years, AI may replace self-help methods, not the medical care. Because there is enough data is there. There
Yeah.
is
Because self help itself is commoditized these days. Indian society sort of looks down also upon self care, right?
Yes. Self-care can be advanced any level.
Mm.
Not, I'm not undermining the market of self-care.
Mm.
Okay.
Mm.
That because we know self-neglect is in Indian nature. We sacrifice for others. But that's a big industry in healthcare sector can come up. And
Yeah.
there AI also will grow. Sometimes AI may generate more revenue, more $1 billion than medical care.
Mm.
See, example I can give the supplementary medicine industry in the US is more powerful than the actual medical care industry because they have huge revenue. It can
Yeah.
grow, but it doesn't mean that that is an alternative to the actual medical care.
Yeah, absolutely. So, what's your general take on burnout, right? So, among working age people, what kind of cases are you seeing at NIMHANS? And what would it take for workplaces to treat like mental health as an important issue?
I can share my experience of 2, 3 agencies. Like I am
Okay.
working in Bharat Electronics Limited. It is a public sector kind of company.
Yeah.
I am part of their mental health care no training programs. I'm also part of these UGC's Malavia Mission Training Center. They train teachers, college and university faculties.
Okay.
So, University of Calicut, University of Mysore, and University of Assam. Many universities have been invited in a year at least some 30, 40 hours of training programs with these kind of agencies. What I notice, we still give importance for hard work. And extended working hours are considered as a gold standard in work life.
Yeah.
But unfortunately, extended working hours or hard work is not going to make India developed country. It will kill your creativity and efficiency. It defined working hours.
Yeah.
What I meant is 6 into 6, no, six, let's say that 8 into 6, 48 working hours or 5 days working hours in a week. So we need to have defined working hours because we have, if you want to be efficient, mind, body, and situation has to be in balance. And when your sleep is disturbed, when your physical activity is disturbed, when your social connectedness is disturbed, it is directly going to hit your mind. It disturbs your way you handle, regulate your emotions, way you use your creativity in solving problems, way you express empathy towards others. All these areas will be affected terribly, and it causes mental problem, just mental issues to you as well as others. Because if you misbehave, it affects you as well as another person. So I strongly recommend 5 working days in a week. I also recommend, if possible, 6 working hours per day. Of course, it may cause some problem in working dynamics, but millions of population is waiting for a job opportunity. Instead of paying heavily for somebody who is doing hard work, why don't you recruit more people and pay less for everybody? Doesn't matter. But this principle of hard work, extended working hours, superheroes in workplace, all is going to affect our mission to become a developed country.
Yeah.
It will hit the youngsters who are waiting for jobs, and they may do much better than these people who are superheroes in workplace.
But in your experience, right? Earlier there was that stigma about mental illness, right? Like if there is someone at your home who's not well, you won't tell even your best friends or your relatives, right? But in the social media era, like there are people who are coming and sort of sharing, their mental health stories, everything on Instagram or YouTube or Twitter, right? So do you think like now everyone uses terms like trigger or trauma? People use all these terms, right? So are we also trivializing then these terms? That's like the other end of spectrum. Like someone who has undergone genuine trauma and someone who's like just talking about work stress or problem with your boss or something, both can't be sane, right?
Yeah. So we have one experience like we are very happy that these dialogues have started. Now at least people are speaking about mental health.
Yeah.
We are very sure that what they are telling is not the facts. A lot of people are speaking different kinds of mental care practices.
Yeah.
But we are aware that those are not facts. But we don't want to discourage this dialogue because we know that we can drive this dialogue to the science of facts.
Yeah.
Gradually. So one tool we have brought is telemedicine. You know that there is a Union government has started some
Yes.
telemedicine, telemedicine.
Yeah.
We have brought it. If somebody has some question further, they can just call to our number and clarify. This is what my expert is telling. Is it true? Our team will be in a position to tell that please don't trust or please go ahead. There will be some system in India to just clarify. Is it true or not?
Yeah.
Even this trauma and all, no, they can give a call to telemanus. I said, I have trauma. I am affected. I have been triggered. Or I have PTSD. No problem. We are okay. We'll listen to PTSD and we will tell you that. Is it a PTSD or a minor, small fight at your workplace? So now we have system in place. That's one thing I should mention that. As sometimes what happens, you spread a message. We can solve everything through self-care. We can solve everything through the supplement medicine, like vitamin D campaign. A lot of things are happening there. No, sometimes some people, especially aged people, global population, who are less informed, they will become victim of these kind of dialogues. Silently, they will be suffering. So they will silently become extremely hopeless and commit suicide. So those who are doing these dialogues, Please be careful and know more. And then let's speak little more facts and science. So we
Yeah.
wish that.
You have these social media influencers sharing mental health content, right? Do you think there should be some sort of control on the way, like the way in which they are sharing info on social media about mental health? According to you, what sort of control do you need? In India, should we have some sort of control on social media when people are sharing?
Yeah, I think a few things. A patient is sharing their experience. Absolutely, there is a freedom of speech is there. Not, in fact, we should encourage the
Mm.
patient, the person who is suffering their experience. Family caregiver is sharing their experience. We should appreciate and encourage because they are telling their lived experience. We need such stories. Semi-trained, informed people now get their ND in certain kinds of medicine in 3 months from Singapore, and then start preaching about psychotherapy or like getting PhD or online 6 months or PhD. So there are many not legally qualified people are speaking about mental health. It cannot be allowed because that will mislead people and they will be wasting their hard earned money and they will be extending their suffering. The two issues there. They will say that hypnosis can be used to handle your trauma issues. There's nothing like that. And they use the mind reading, mass mind reading kind of thing. All are extremely cheating. I can tell only one word. You are looting. Instead of that, you can loot money. Just direct pickpocketing you can do. Instead of doing this kind of, you're not trained. You're not licensed. Then who are you to tell this is how you can handle mental health? You can't handle. Whether it is religious people, whether it is this other alternative care professionals, whether it is international delegates, who allowed them to tell like that?
Yeah.
Because they just because you are from Stanford University, it doesn't mean that you are an expert in mental.
Mm.
Mental across the world, there is a defined qualifications are there. You can refer the Mental Health Care Act. There are 3 4 professionals are qualified with the training through supervised training within the mental health care settings. But I also want you to add that element. There are MBBS and the training in psychiatry, MD in psychiatry. They are eligible to practice. Earlier, we had a diploma also. Say we have MA in psychology or MSc in psychology with MPhil in clinical psychology. They're trained in the mental health care. It's similar in social work with the MPhil in psychiatric social work. They're eligible. Similar in nurses, again BSc nurses and training in nursing. Other than that, people with any other degree teaching mental health is going to do harm because they don't have that enough experience or enough training to judge situations. So this is the error in the influencers thing. So it is making a fake communication. Because if I am not trained in the homeo medicine, can I speak about homeo medicine? It is something illegal, right? No,
Yeah.
right? No, same example I'm giving.
Mm.
So of course, all of us have a mind, all of us issues. It doesn't mean that we can predict others' mental problems.
Yeah.
Your
Absolutely.
self experience is not enough to treat another person.
Yeah. But
Yes.
there are very few institutes of excellence like NIMHANS, right? I remember I come to NIMHANS with a friend. I had to stand in a queue for like 3 hours just to, meet a junior doctor. Not even the main doctor. So first he will screen or consult and only then you can. Are our institutes able to manage these huge loads? Like, are we investing enough in mental health?
Yes, we are not prepared. That
Mm.
is the reason all these things are happening.
Mm.
Why we are not proposing or propagating any legal action against the people? We know that all these people who are speaking about mental health, they are somehow connecting with who are suffering. That much is up,
Mm.
but it's not the actual thing. I can give you some positive news. One is telemanus.
Yeah.
Somehow you can identify an institute with a law kind of service. Another thing, all India aims have a psychiatric department. All aims have a psychiatric department. At least they do fairly good work. Similar way, every state has the state institute of psychiatry. All states have. Now I don't know about the northeast region. 1 or 2 states may not be having, but otherwise all states have one prominent state mental health institute. But if you ask me, is that enough? Not enough. We need more professionals. And what is the strategy we are evolving now? So now in psychotherapy, we are starting as part of allied healthcare professional, a bachelor's degree with this clinical supervision, like BSc nursing. We are starting, and very soon, in a year, there will be at least 10,000 people, bachelor degree holders will come out of from psychology and social work, and they will be capable to provide first aid, psychological first aid. This policy is started this year onwards. It is going to happen.
Yeah.
Bachelor's degree program, and we also are planning to promote the public-private participation. Now Manipal Institute or CMC will do, or SRM Institute, or like the many institutes even in North India also, they are starting these courses.
Oh,
So,
bachelor.
yeah, private institutes are taking up this initiative, bachelor's program. So we'll be having at least they won't do harm, like BSc nurses, no? They know what is the medical care. Either they will care or they will facilitate the medical care. What I visualize next, in another 2 decades, we'll be having sufficient primary care system in the mental health. But the specialist care, I think we need to take a little more longer time. Another 3 decades we may take to reach the enough number of specialists in our country. But government investment is not enough. I'm not telling central government investment. Why not state government? Health is a topic of state government also. Why can't state decentralize their mental health care systems within the state? Like I take the Maharashtra. Why can't we have at least 6 regional institutes within Maharashtra? And look at the local culture and local needs and design a strategy. The amount of decentralization of training is important. Otherwise, NIMHANS driven. I was after agreeing this discussion review, I was just simply looking into the data, concentrating in a lot of professionals in Karnataka. Why it happened? Because we had an immense like institute here. Karnataka, Tamil Nadu, Kerala, we can see little more number of mental health professionals because of presence of NIMHANS in southern region. So why can't we develop the Central Institute of Psychiatry, LGB in North Edgeport, like that we have regional institute. Let's develop into the demands kind of institution with a little more better funding from state as well as central governments. So this has to happen. This lobbying has to happen because we know that cardiac or the cancer care, there are private people are ready to invest because profit is more.
Yeah.
But in the sector of mental health, especially private hospitals, they cannot invest heavily in this area because to understand the scope and profit. You
Yeah.
don't have any surgery, you don't have any costly investigation. Medicines are not that costly. So people think that may not be that profitable. We need to make it more cost effective our treatment and more business opportunities in the psychiatric care. It is yet to evolve. Yes.
There are a lot of new private players setting up hospitals, right? Including, I think, inpatient care in Bangalore and all.
Yeah.
Do you think that is sort of improving the access for mental health? Stepping into one of them, the sort of, atmosphere they had was like, it had like, the jail kind of thing for the inmates with rails and all that. At least in Kerala, I've been to one and they had rails and all for the patients, right? Like if you are to take someone to admit they're a loved one, then you will think twice, right? Like it's not like going to a hospital. The experience is very different. So are our new private players sort of changing it?
Yes, I can give one or two examples. I don't have any direct investment. This is a disclaimer from my side. I don't any relation with this organization, but I have found that Kandabams in Bangalore and Richmond Fellowship Society in Bangalore, and then Spandana Hospital in Bangalore, and then these are all care homes or care centers. They do really well, and they provide a kind of resort kind of ambience and you don't feel that you are in a mental hospital. No jails, but still safety purpose, the external doors of the entire premises may be low, but otherwise inside the campus, they feel like a home kind of or a community experience.
Yeah.
Village kind of experience. I have visited and I really feel that private people who have really designed such kind of care, they are getting profit
Yeah.
and clients are happy. We want many more such models.
Yeah.
Also tell like clinical care, like OP care. One of my professor, my friend, Dr. Naren P. Rao, he left NIMHANS. He was in peak of his career. Like he was a professor at here, was a rank gold medalist here. He left NIMHANS, started as clinic. Now we need to wait 3 months to get his appointment. Means he could create a chain of hospital within Bangalore, like 5, 6 clinics. So you need not come to one center. We can have different centers, satellite clinics, and he has clinics in Karnataka, different cities, even in Pune. So what I'm telling the new graduates of psychiatrists, they should not only think about the practice in psychiatry, and there's a business opportunity
Yeah.
and there is a profit, then there is an employability, the employment opportunities also they are doubling. So newly finishing graduates, they're getting employment, therapists getting employment, online consultations they are starting. So this kind of spreading the service by professionals will reduce the space for fake kind of
Yeah. Because I think in India, like if someone is diagnosed with a mental health problem, they will try everything from analyzing energy in your home to all the pujas. Even if you consult a doctor, still they try everything, right?
I would like to tell you, I want you to quote this example in your article or wherever you are
Yeah, yeah.
highlighted. If your washroom plumbing problem, like if something is leaking, if
Yeah.
you try to repair yourself, you know how horrible it is.
Yeah.
You call the expert, 15 minutes, that person will complete the task. You will be having peace of mind.
Yeah.
Same way, if you try to handle it by yourself, you will be messing it up and you'll be facing a lot of troubles. You need an expert, trained, qualified expert. They will guide you and there will be less chaos and you can return back to your job or routine life much earlier than the self kind of remedies or home remedies or faith-based different.
Yeah, absolutely. Coming to your favorite topic, that is the district mental health program, right? Can you elaborate how the model works and the importance of community models, right? Like task shifting, train local workers to reach people outside the big cities. From your experience, where are these models working well and what would make them stronger and last longer?
Yeah, I think see our healthcare system. If you understand, the baseline community workers are ASHA workers, and sometimes the Anganwadi workers also share responsibility, especially maternal care, child health care,
Yeah.
and we also have school teachers also sometimes share the responsibility of reaching out people because they are readily educated people available in the community
Yeah.
and school and college teachers and Madi workers, the primary healthcare centers, the doctors, no primary healthcare centers. And then comes these are our grassroots level kind of workers. After PHC, we have a community healthcare center, CHC. District hospital is the one nodal office where usually this DMHP, the professionals will be situated. And what is happening, I would like to tell you, in Karnataka, this model is working well. What they do is they have district level doctors are there, psychologists and social workers are there, and they go to the community healthcare centers like in rotation. People can travel 30, 40 kilometers and they can reach these community healthcare centers.
Mm.
So they need not travel 500 kilometers overnight journey and all to reach the mass. Yes, district hospitals also they get aligned, this district DMHP aligned with the local physicians. If they find some problem, and refer to DMHP. And DMHP will supplement the medication. I have visited a Karnataka Srinivasapura primary healthcare center where the Respiridon kind of severe mental illness medications are available
Oh.
like depression, bipolar affective mood disorder medications are available in a local primary healthcare center. So the doctor either he can diagnose in consultation with the district level doctor or he can refer to the doctor. They can refer back to the primary healthcare center for further monitoring. Any adverse events are happening, again they can refer back to the DMHP. and telephone numbers are available 24 into 7. They can contact these doctors. So what I would like to tell you, district health, district mental health team in collaboration with the taluk and the panchayat level kind of care system. This network, if it is well established, this system will work. We have a district public health. We have declared as a public health observatory. What they have done is they brought the Tata Trust. Tata Trust will coordinate the getting appointments for your specialties in government sector. It's like a passport seva kendra. Passport, who is bringing, giving documents? Government only. Who is verifying document? Government only. But passport seva kendra will coordinate. Same way, Tata Trust is doing amazing job of coordinating between public and government only providing service. So we need this kind of models. So when slots are available, when beds are available, like the Make My Trip, railway is by government, traveling is public. Make My Trip will inform you where service is available. So that itself is a business. So we need this kind of novel private partners in facilitating care. So where no appointment can be, your experience of visiting demands. You had a bad experience because no passport server kendra. It is demand is increasing. It totally demands aims, waiting time at aims.
Yeah.
Secondly, it's huge. Compared to aims, we are far better. We are doing much more better. You need not wait for 3 4 days. Only
Yeah.
things you need to come early. You need to go within same day. You can have a consultation. Number is huge.
Yeah,
So
yeah, absolutely.
yeah, these kind of technology we need now to facilitate local resources. The state is a model, Kolar, with the help of public. Please read about Tata Trust in Kolar district and how they facilitate government care for public. Government medical care. And there is a call center also. So if you just know, "Hey, I don't know which medicine I should take," you can call the call center. One nurse will guide. That is actually funded by Tata Trust, not by government.
Okay.
And they will be very professional, like call actual call centers. It's a very good model. I would like to tell that this district members we had a major challenge also. We should not speak only about positives. Major challenge is funding. The amount we are giving for the salary is paid very less for social workers, psychologists, is around 30,000. They feel it is equivalent to the ambulance drivers earning, and they don't do really well. So the salary has high. This was to reach a kind of how NIMHANS is paying. NIMHANS is paying a graduate who is practicing a 75,000. And you are paying 30,000. The same level therapist, no, you are paying 75,000. And if somebody is 30,000, how they will stay back in a rural area?
Yeah.
Then naturally will migrate to the better institute. The demand is very high, supply is less. So they will be getting opportunity in the better institute. In private sectors, they are ready to pay around 75,000 for such graduates. So they won't stay back in the DMHP. There is attrition is very high. That is another major. Funding, attrition. These are the two challenges. Otherwise, public, they're aware. People within the government system, they're aware. The system is quite good. It's also proposed taluk mental health system. The district pilot testing research is happening. Very taluk, there will be a designated doctor will be in charge of mental health, including psychotherapy. It's a new project led by our Dr. Jagdisha Tirthahalli, and it's excellent initiative. Taluk mental health program. So as the system is growing, and they are also connected, and DMHP is now well connected with the telemedicine and police. In Karnataka, another good initiative is police, telemanas, DMHP. They are connected like a triangle. If police find anybody mentally ill, they can refer to DMHP. And or Telemanas finds anybody who is having problem, they can refer to DMHP. And DMHP finds any crime, they can refer back to police. Telemanas finds some emergency like crisis management, somebody is becoming violent because of mental illness. Telemanas will connect to the police. Police will bring them to the DMHP. So
But
this
how address this problem of continuity of care, right? Like, because I feel in India, access. Imagine if you have like bipolar or schizophrenia, people are consulting doctors, they are taking medicine, but then once they are better, right? Then there is a gap between someone who's like, okay, they are better, but then they are not consulting the doctor because again it's difficult, it's expensive.
yeah.
So,
Yeah.
um, so how can we address this gap of continuity of care, especially in tier two, tier three towns, right?
Yeah, I would like to.
Mm.
Yeah, I would like to
Let me
tell
just
you some
finish
stat.
thought. Like a bipolar or a schizophrenia is not something which will happen for 1 year or 2 years. How you're consulting a doctor for diabetes, you need to like constantly see a doctor, tweak your medicine. You might need therapy, reduce your reliance on medicine. Some of them might be reluctant to take medicines. But then the initial 5 years, they might be consulting every year. Then, they might not consult for the next 10 years. Then the patient might be reluctant. So, how do you address that sort of an issue in India?
See, that's what I wanted to tell you. In US, adherence of treatment is 40 to 50%.
Non-adherence of treatment is?
So of treatment for BPAD, schizophrenia is almost 40 to 50%.
Yeah.
India also non-adherence is around 45 to 60%. Hardly 10% more than US rates.
Mm.
You compare the US medical system and Indian medical system. The problem is here BPAD and schizophrenia. Issue is their inside. Somebody thinks I don't have any problem. Continuing medication will be extremely difficult.
Yeah.
We are not treating it as we are not considering it as a challenge in treatment. We are considering it as one of the symptoms of our diagnosis. Like not thinking I have problem. It is very common in BPNE and schizophrenia and schizoaffective. Some typical cases are there. It is very common. Why we need multidisability, community outreach, tele follow-ups, hospital-driven kind of care, or kind of a kind of treatment, we'll say that community based treatment approaches, community re-entry programs. We need social care actually. Actually speaking, what is missing is social care. In Germany and all, they have somebody called visitors, social care visitors. They visit homes and just check how things are happening. India is yet to establish a social care ministry. So we have health and family welfare, but that's not enough to the social care part. Somebody is not willing for treatment. Somebody thinks I am all right. And all these people need to be reached out.
Yeah.
We had ASHA workers as an alternative of these community social care workers. But they are not trained enough to negotiate treatment. And they are multitasking, they
Yeah.
have pregnancy related work, they have infection control, COVID control, lot of work. So they cannot really focus on mental health related outreach work.
Yeah.
We need a separate cadre of community outreach workers for mental health.
Mm.
That will be a revolution for India.
Mm.
Of this continuity, identification, faith-based fake healing system and all will be naturally will collapse.
Mm.
But if we have this thing, and why it is important, I would like to bring your attention one more point. Our aging population is increasing.
Yeah.
By 2050, we will be having 20% of aged population.
Yeah.
How we will ensure the care? Whether children will ensure their care? I don't think so. So we need this cadre who will look into the mental health of people at community level.
Yeah.
It
Absolutely.
is completely missing. It is completely missing. It can be a next job opportunity. It can be a private people also. It can have public people also.
Yeah. It's about um how we ignore the mental health of children, right? Like children and young people, they carry a lot of stress and burden, but there are very few specialists for them. So from your view at NIMHANS, like are there a lot of kids coming to your hospital, and how can we sort of bridge this gap? What can really address this problem? Can school play a role, or is it only psychiatrists can play a role, or something, or do we need something else?
School mental health program, lot of schools with the school counselors is very less. And then college counselors, only affordable colleges they have.
Yeah.
Any college that they don't have the college counselors. They are the one who can identify this problem early.
Mm.
Anganwadi workers outreach and all happened very well. We have trained enough. Anwadi workers to identify the especially intellectual disability and early childhood problems they are identifying and referring. But do we have enough child care specialists? Again, answer is no.
Mm.
It's very less. We don't have adequate child mental health care specialists in India. And do we get children? Yes. Our OPDs are full. And because of it is full, people are not coming. That's the problem. So it is not the problem, not aware about the illness, but nobody is full. They won't get leave. Children will not get multiple now leaves from because now the permission from the schools. So this it is again it is complicated because less resource problem is huge. Like give one statistics. Obviously, it is the already people are aware. 10% of children are having learning difficulty or disability. How they are identified, certified, and who give their remedial education. And next, if we are looking for a Vigasit Bharat, this is a huge service gap. Identification of learning disability, mediation of learning disability problem, and nothing is happening. Children with extreme, like mood disorder, depression, associative disorders, ADD, they're all getting some form of service. But there are neglected areas like learning disability uh, to provide proper services. These are my insights from our experience. I mean,